And so I'm going to talk about enteral access and nutrition. As gastroenterologists are very attached to nutrition and nutritional support because, first of all, our patients with digestive disorders are very often malnourished and need nutritional support, and also because we're endoscopists. And so we are the ones that mostly will insert the enteral access, which is useful for nutrition. So this is what we're going to talk about today. So enteral nutrition is short or long-term delivery of nutrients and medications into the GI tract of patients who cannot maintain their needs with oral intake. So why would we use the gut? Because it's more physiological. So if the GI tract is functional, you should also prefer to use it instead of parenteral nutrition. We know that it has better clinical outcomes. There's a lower rate of complications, including sepsis, compared to parenteral nutrition. So this is about enteral nutrition, but sometimes we will need enteral access for palliation. And sometimes we have these patients that will have multiple obstruction of the digestive tract because, for example, of gynecological or digestive malignancies, and will not be able to have oral nutrition or even enteral nutrition, but they will still have oncological treatment. They're not amenable to surgery, and in this case, they will need vent access, gastric vent access for a decompression. So this is another use of the enteral access. So we have different access devices, and this really depends on two factors. One is the duration of the nutritional support, and the other is the underlying pathology. So for the short-term access, we'll have nasoenteral feeding tubes, either gastric, either jejunal. And the long-term access, we will have percutaneous access, which are most frequently percutaneous gastrostomy. But we also have the jejunal long-term access, which is gastrostomy with jejunal extension, and also direct percutaneous jejunostomy. And this time, let's say, limit is randomly decided to be about 4 weeks. So when we'll need nutritional support more than 4 weeks, we will probably prefer to exchange the short-term access with a long-term access. So this is a schematic representation of the different access that we have. So this is the more frequent one. It's the percutaneous gastrostomy. The percutaneous jejunostomy, the direct, is the enteral access that is directly into the jejunum. And this is the gastrostomy with the jejunostomy prolongation, so the PEG-G, where you have a gastrostomy, but the nutritional support is administered through a jejunal extension that goes further down the jejunum. So we talked about the duration, but also the different clinical settings are important to decide what kind of access you will choose, and especially if you're going to choose between the gastric and the jejunal access. Generally, the indications for long-term nutritional support, mostly from the gastric access, which is your first access to consider, are patients with swallowing difficulties, either in a neurological setting, most often stroke or motor neuron disease, facial trauma, and mechanical obstruction, mostly due to head and neck or esophageal cancer. And then you have this large group of patients which have can have oral support, oral input, but will be insufficient because they have a great catabolism, and they will need an extra boost compared to the insufficient oral input that they have. So these are patients with chronic diseases like pulmonary diseases, cystic fibrosis, cancer patients, and of course ICU patients. And then we have the patients that will need gastric decompression because of long-term obstruction non-amenable to surgery. We will have to choose a jejunal access if there is additional clinical factors such as gastric or duodenal obstruction, where of course there's a gastric outlet syndrome, and we cannot use, infuse the nutritional solution in the stomach. When there's a gastroparesis, because we have to bypass this problem. And of course, there's some alterations, anatomical alterations after surgery, after gastrectomy or gastric bypass. And another indication to switch from gastric to the jejunal axis is when there is a risk of inhalation pneumonia or imported reflux, which prevents optimal administration of the enteral feeding. And finally, acute pancreatitis has been traditionally indication to administer the enteral solution in the jejunum, but we know that a gastric axis is also possible, and it will depend on the tolerance of each patient. So we'll talk about the nasoenteral, nasogastric, and nasojejunal feeding tubes. Nasogastric most often is bedside insertion if there's no anatomical alteration, and if there is difficulty or if there's known anatomical problems like previous surgery, gastric surgery, then we will do it with endoscopy, under endoscopic control. Nasojejunal most of the time will need your job as an endoscopist. This can be done either with a nasogastroscope through the nose over a guide wire, or through the mouth with a standard scope and an oropharyngeal transfer if the nasogastroscope is not available. And we can use also the drag and pull with endoscopic forceps. And most of the time, we will need fluoroscopic guidance. There are new techniques now with feeding tubes, nasogastric or nasojejunal feeding tubes that have a real-time image-guided system where you can see where you're putting the tube. And this, first of all, will reassure you that you are well into the intestinal tract and not into the trachea and the lungs. And also that if you want to go to the post-pyloric, after the pylorus, into the duodenum and the jejunum, you can achieve this with real-time visualization. Also, there are also types of control where you can see the route that you're taking with an electromagnetically guided bedside placement. And you can see that this is a nasojejunal tube where you see the C arm of the tube going into the duodenum. Of course, these techniques are not widely used, and they're quite expensive, but there's some interesting data on this on these new devices. So what about the complications? Because these seem routine acts that we do every day on the bedside, but there are complications related to them, such as bleeding. And of course, the most frightful is the advertent placement in the respiratory tract, which can really have a high morbidity with respiratory tract infections and even death. And or pharyngeal or esophageal perforation, which is fortunately rare complications. Long-term complications related to the tube placement is, of course, dislodgement, migration out of the small bowel or the stomach, and tube occlusion, which is more frequent if we estimate gastric residual volumes, like like our colleagues in the ICU like doing. If we give medication from the tube, that's why it's important to avoid this. And if the patient can swallow his medication, to prefer to give them by oral access and not by the tube. And of course, with longer and thinner tubes and continuous infusion and not enough flushing. Other complications, long-term complications, are sinusitis and also rarely strictures and perforations after long-term placement. So it's important to confirm correct placement of these nasoenteral tubes. Most frequently we will propose using X-ray to see that the tube is well into the digestive lumen, simple chest X-ray, And in some recommendations, the test of the pH or the pH strip on the liquid that comes out of the tube, which of course we can imagine with all the patients on PPI might be a problem. Also, we have the typical testing of listening, so listening the air insufflation, and also a good trick is to put the end of the tube once placed inside a glass of water. If there are bubbles coming, it means that you're in the lungs, and so you have to control your placement. And of course, with the new techniques, the new tubes, you can have a direct visualization. In any case, this is very important because you can see here, these patients might not cough, might not show signs that you're in the wrong tract. This is a patient that we had the next day. He had, after feeding tube was inserted, he had respiratory failure, and the CT scan showed that the tube was really into the right bronchus, and he had very important pneumonia. So this is a simple technique, but can have really very, very important complications. So we're going to talk about the long-term access, so gastrostomy. We have many different models with many different diameters. Most frequently, you will have an internal bumper, as you see here and here, or an inflated balloon to keep the tube in place. And you can have different insertion techniques. This is either the pull or the push technique, we'll see later. And this is also something that we do routinely with a very high technical success. It is important, of course, to have a checklist before this procedure, because although it's routine procedure, it is performed usually in patients with great comorbidities, very fragile, and you can have mortality rates reaching 10 to 20% according to additional cumulative risk factors. So the indication always is important. We know also that dementia, psychiatric disorders are very poor income. So you always have to talk with the referring physician if the indication seems a bit out of order. Also the clinical condition of the patient because of their fragility, and discuss if we can do it with sedation or anesthesia. Coagulation, of course, you need an INR 1.5 and at least 50,000 platelets to do this procedure safely. Patients should be tested if they have anti-aggregation, anticoagulation, and these should be interrupted according to their half-life. The only anti-aggregant that we can allow is aspirin, and we can put percutaneous access with patients on aspirin. Any previous digestive surgery, this is important because if the patient, you've discovered that while you're trying to put his gastrostomy has a Billroth or previous Whipple procedure, this is another type of it's not a gastrostomy, it's a jejunostomy, so it's a bit more complicated. So this information is important to have before you program the procedure. Also, if you have ascites or peritoneal dialysis, because of course, the peritoneal cavity has liquid that can be infected during the procedure. So this is a relative contraindication. Again, you should talk with the referring physician and explain the risks to him and to the patient. And during the procedure, we give prophylactic antibiotics. One shot of cefazolin has shown to drastically reduce the risk of infection after placement. So the two techniques. So the pull technique is a typical technique where you will use the endoscope as a visual, but also as a manual tool to with a snare to grasp a string that you're going to put through the introducing catheter, and then you will bring it out, and on this string you will attach the gastrostomy tube, which will have an internal bumper, which is pulled through the mouth and through the skin, and will end up outside the abdominal cavity and outside the abdominal skin. And the push technique is indicated when you have an obstacle, neck or esophageal neoplasia. And this is important to avoid seeding because the passage of the very troublesome for patients that have a complete local control and will come out years later with these metastatic lesions were very hard to treat. And a recent meta-analysis shows that you can reduce this risk to from 0.5 to 0.29% by using the push technique. So the push technique, the characteristic of it is that the endoscope will be only used as a visual support. So you can pass with a very inserted abdominal wall and the skin immediately into the gastric cavity. And if you do this without putting what we call these gastropexies, you will push the stomach and you will might end up having air around the gastric cavity in the peritoneum, and then you will not be able to put the tube. That is why these gastropexies will help keep fastened the gastric wall against the abdominal wall and able to push the tube inside without pushing away the gastric wall. So this is how it looks, and you have a very good maturing of the fistula tract once this is stuck together. And this is the little anchors that we use to do this. You put 2 or 3 anchors and you can put the push gastrostomy in an easier fashion. So if you want to need a jejunal long-term access, we talked about the gastrostomy with the jejunal extension. You will have a larger gastrostomy tube in the stomach at 24 or 20 French. And inside you will insert the jejunal extension, which is a 12 or an F9 French jejunal extension. This, you will need fluoroscopy to do it because you have to see where you place this jejunal extension. And it can be done either with a biopsy forceps where you drag your extension down to the jejunum, either over a guide wire, depending on the type of tube. And finally, the direct jejunostomy, it's the same principle of the pull technique for the gastrostomy, but here we'll have to go further down outside the pylorus after the Thwaites angle in the first loop of the jejunum, and you will have to use either an enteroscope, either pediatric colonoscope, or even a colonoscope can do it, depending on what you have. But you have to progress a bit further down. You will again use transillumination, and we use the gastrostomy devices like we put in a routine gastrostomy. You might need fluoroscopic control, but not always. The characteristic of this technique that it's the technical success is lower because the jejunum is floppier. It's difficult to find the transillumination according to anatomy. So, and it will take longer. So in this case, we prefer to have anesthesia for the patient. So what are the complications related to this procedure? As again, these patients are fragile, so aspiration can be a problem related to the supine position, advanced age, if they have neurological impairment or not, and need for sedation, which is important to evaluate the patient beforehand and to definitely propose general anesthesia for patients where you need to put the jejunostomy will take longer. Patients that have a very important neurological impairment with altered consciousness and patients, for example, that have a tracheostomy. Another complication could be acute bleeding if you get a large vessel which will not have a visual of it. This is this is very rare. Most of the time you'll have some bleeding on the puncture, which can be managed by putting an extra suturing if necessary. Puncturing the small bore of the colon can happen during the procedure and can become diagnosed many months later, and when there's a subsequent fistula. That's why it's very important to use a test syringe when you try to find the transillumination and the good site of puncture, where you puncture while aspirating. You have some water in this, some xylocaine in or serum inside the syringe, and while you aspirate and you see bubbles, you are in a cavity with air, and you have to have a visual and see your needle at the same time. If you have bubbles and you don't see your needle, you're somewhere else, you might be in the colon. So this is not the good tract, and you have to find another tract. Transient pneumoperitoneum can be visible after gastrostomy, and it can happen also in absence of peritonitis, especially when you're going to use the push mesh and you don't have a gastropexy. As we said, you can push away the gastric wall, and you will put air around it. But if the patient has no symptoms and there's pneumoperitoneum, there's no indication of having any treatment. You might have, on the other hand, some peritoneal leakage of fluid that can take place. In this case, the patient might have pain, ileus, and high CRP levels, sometimes fever. In this case, the vast majority will resolve only with antibiotics and waiting a bit before feeding the patient. So related to the tube, long-term complications are not infrequent. We can have infection on the site. This is can be related to patient characteristics. Patients that have RBs, have diabetes, are very malnourished, and have steroid treatment. Technical factors such as small incisions where the orifice is very tight around the tube if you don't give prophylactic antibiotics. And there's extra tension between the bumpers, which might give ischemia, can lead to infection. Nursing care related, as we said, excessive traction between the bumpers. And most of the time, these are infections that can be controlled with local antiseptic like ixobetadine, and sometimes systemic antibiotics. They will rarely lead to severe forms of peritonitis and necrotizing fasciitis, but this has been also described and might even require surgery. Excessive leakage around the orifice can be a concern. This can be due to increased gastric acid secretion, where we can give PPI to decrease this. Gastroparesis with high gastric residual volumes, and prokinetics can help. Sometimes you can have also a bacterial fungal cutaneous pexide infection or granulomas that also will give this leakage. It will be resolved if you treat the infection. And also if the use of many different corrosive agents can be an aggravating factor, and it's mostly better to just use some water and soap to clean the area and keep it without addressing after the fistula tract is matured. There are some specific complications related to the gastrostomy. So the buried bumper syndrome is when the inner bumper is completely covered by the mucosa, and this can be diagnosed if there is difficulty in giving the enteral nutrition, and if the tube cannot be mobilized. And this is an important act to do for the nursing. And it's something that can occur quite frequently, and it's very important because it will definitely require either endoscopic treatment, either sometimes surgical treatment. And so this is very important to prevent, and to the nursing here is in information is very important. We talked about the tumor implantation, the metastatic tumor implantation on the gastrostomy site. So it's important to use the push technique to avoid this as much as possible. The inadvertent extubation of the PEG tube, if this happens before the maturation of the PEG site, so within 2 or 3 weeks, this can be a problem because you cannot put back the tube easily. If it happens after 4 weeks, the tube is definitely mature, and in this case, you should not hesitate. You should put back the tube just to keep the PEG fistula open. It can close very quickly within 3 or 4 hours, and we have to do the whole procedure again. So it's also very important to drill the nurses to put the tube back in place, and to schedule a visit to replace this with a functional tube with a functional balloon again. And we talked about the fistula with the adjacent organs and the colon. So this is some photos. You can see here, this is the buried bumper. So the bumper is underneath and the whole gastric mucosa is grown on top. And there's only a little orifice there where you can still give the feeding. That's why it can progress, and we do the diagnostic too late sometimes. But here in this case, we managed with a needle knife to cut around the mucosa and to free the bumper, and we put in place balloon, where you have, of course, a very lower risk, and not a risk at all to do a buried bumper. This only happens with the pallets, the bumpers, the internal bumpers. A PEG G, those are the PEG with the jejunal extension, also can have complications. The most frequent one that will require extra interventions is when this jejunal extension will flop back into the stomach. And this will arrive quite frequently. It will happen more often in a patient that has a large atonic stomach, like patients with gastroparesis or vomiting. It will happen also related to the way that we put the PEG-G initially. So if you have a gastrostomy that's very high in the fundus, where you have a long tract of the jejunal extension, this will happen more frequently. But it is also difficult to perform subsequent procedures in these fragile patients. When this happens, also if this is repetitive, it could be an indication to try a direct jejunostomy, especially in cases which will really need a jejunal access. Another complication that you have is duodenal ulcers or fistulas that will happen here in this area due to increased tension of this jejunostomy. And this might also require exchanging with the direct jejunostomy. And finally, the case of the direct jejunostomy. It's a very attractive technique for patients that require jejunal access, but the technical success, as I said before, is lower, about 85% according to the studies. And in this large study with more than 300 patients, from the States, there was a very high rate of adverse effects and even serious adverse effects in more than 20%, and serious adverse effects in about 5%, including bowel perforations, volvulus, bleeding, and aspiration, and even one case of mortality. So this is a procedure that should be done only in centers that have the expertise and also have a digestive surgeon as a backup to help. And here is one of the complications we had in our series, where there was this volvulus, the jejunal volvulus happened, and this was because the jejunostomy, the tube was twisted, was rotated, and this should be never done in a jejunostomy because in contrast with the stomach, which is fixed, the jejunum is floppy, it's not fixed. So if you turn the tube, you might also rotate the jejunum and create a volvulus. So we never rotate the tubes when it's a jejunostomy. And this is also one of our patients that unfortunately had a colon fistula. And here you can see the tube was placed into the jejunum. We see that initially the jejunum is classified with contrast, but afterwards we have the colon, so there is a contact between them, and this was diagnosed many months later after the placement of the jejunostomy, because there was fecal matter coming outside of the tube. The patient also required surgery. That's why it's important to, when you're placing the tube, to really take care to try to avoid the colon by doing this aspiration technique, as I said earlier. So after it's inserted, the aftercare for the gastrostomy, after insertion, the tube can be used after 4 hours after insertion for feeding. The patient can eat. We do not mobilize immediately. We will let the fistula heal a bit around, and we usually do this 3 or 5 days after insertion, with these in-out movements that are very important to continue once per week to avoid the buried bumper syndrome after the patient is at home or out of hospital care. Once the orifice is mature, you can leave it open without dressing. If it's a plastic bumper, it's very important to do the in and out movements once a week. A balloon also needs a weekly attention because you have to check the water contents once a week. And if they're less than the 10 mLs that you had put or the 15 mLs, you have to add to have the balloon well filled up to avoid that it will get displaced once it's deflated. For the jejunostomies, we will feed, if it's a PEG-G, we can feed also, we can use it after 4 hours, but we will wait a bit more if it's a direct jejunostomy. We'll wait 24 hours, and again, we will not mobilize it we will wait 5 days to mobilize the tube. And again, as I said, you never rotate, only in and out movements to avoid a volvulus. Ethical aspects are important. That's why you also should communicate with the referring physician. We're not only technicians, we're also gastroenterologists, and also always discuss the medical benefit for the patient. And there's also the quality of life. Will this help the quality of life, this act? There's always risks, so these should be discussed because this sometimes is considered as a routine, very safe procedure from our colleagues. And also, if the patient can be informed, he should be sufficiently informed in case of neurological problems, which is unfortunately one of the frequent indications to put the tube. The family should be sufficiently informed. And this is our role as gastroenterologists to do that. And also always take into consideration the social, cultural, and religious context when we are asked to do these procedures. So to finish, we see that as our endoscopists, we have a predominant role for gaining enteral access for enteral nutrition. We see that there are many devices and techniques, and the choice should be done based on the duration of the enteral nutrition, the underlying pathology, and the center expertise. And it's also very important to know the devices that you are using. You're also supposed to identify and handle the complications, and also take under consideration the ethical aspects, which are very important when we take care of these patients. Thank you very much. So I will see if we have any questions, and please come up with the questions. So there is a question here about the indication of tube removal. This is a very good question. The tubes can be removed if the patient, for example, has a neurological condition, has a stroke, and he will get better. And in this case, what we will do is we will stop using the tube. We will not take it out immediately, but we will wait to see if this only with oral inputs, only with oral feeding, he will be able to keep his weight. He will not lose any weight. There will be no complications related to this oral feeding. And when we wait 2 weeks, and if this period is without any complications, in that case, we will remove the tube. The questions also about tube removal is if we always have to remove the internal bumper or not. We can leave the internal bumper, we can just cut it and leave the internal bumper to be eliminated. But if the patient is in good clinical condition, we prefer to take it out. In any case, when there is previous surgery and there might be some stenosis, anastomotic strictures, we prefer to take the tube, the internal bumper out. On the other hand, for patients who have a jejunostomy and an internal bumper tube, these patients are very fragile. We do not want to procedure to scope them again. So in this case, we just cut it and we push it in, and we give them some cathartics, some colon prep to be sure that they have eliminated this internal bumper. So we're reduced from bleeding, risk of bleeding. So as I said, pay very much attention to all the antiaggregants, anticoagulants. There are so many new ones coming out that us as gastroenterologists, we don't always know them. So in this case, we always have to talk with the referring physician to be sure that this has been done. When you do your cut to put the tube in, we say that according to the diameter of the tube, you have to cut between 7 and 10 millimeters. You don't have to be too generous when you cut, but these are probably the only tools that we have to reduce the risk of bleeding, because the internal bleeding, we can do nothing about it. Another trick is if you have a CT scan that's available, you can check it out before putting the tube in. If there's any vascular important vessels that pass, if the patient has collaterals, you can check them on the CT scan, and you can take your precautions. But mostly this is the important bleedings. We cannot do anything to prevent them. What else do we have here? So the feeds that we use, this is also an important question. We use routine feeds, which is with high proteins. We prefer high proteins to have a good ratio of protein and carbohydrates. Usually we choose energy intake of 1.5, so you can have a good energy and protein overall administration with a reasonable amount of liquid, because you don't want to fill their stomachs up too much. So with 1.5, you can have enough calories with 1500 mLs, for example. So this is something that we use routinely. In some cases where you really have to restrict your liquids, you will give, we also have 2 kilocal per ml, and this also you can restrict your liquids if you have patients who actually have renal problems and cannot give too much liquids. And we give the same type of feeds for gastrostomy that we will give from the nasogastric tubes. For the jejunal axis, there are some patients that will not tolerate well the hyperconcentrated 2 kilocal feeds because they may have some pain, abdominal pain, and unwellness, like a dumping syndrome. But this won't happen to everybody. But in any case, we'll always start with a standard feed of 1.5 kilocal. So another interesting question is when we will change the PEG. So we change it according to how it is used, and if there is if the tube is, you can see that it's has fissures, and if it's breaking, usually we'll not change it too often. At least we will wait for a year before changing it, and most of the tubes will be well maintained for a year. So I would say after 1 year, we will start checking the patient, see if you have to change the tubes. That's for the internal bumper ones. For the ones with the balloon tubes, those you will have to change them maybe a bit more frequently, because the balloon will digest, and we change them every 4 months. In any case, we will always give an extra balloon tube to replace from the nurse or the caretaker, in case the balloon is deflated. So gastric motility, that's also a very good question. This is very important in patients which have respiratory problems and might need lung transplant. And we know that these patients will develop gastroparesis because the lung transplant, there's this injury on the vagus, and we really want to avoid the reflux and the inhalation pneumonia in these patients. So in patients which have these problems and are listed for lung transplantation, we always try to put jejunostomies as a first act. And in this case, these patients will have gastric motility studies beforehand. In the other patients, in the other indications, we will put gastric feeding unless there is been problems with the gastric feeding, the nasogastric feeding, like inhalation pneumonia. In this case, we will put jejunostomy. So gastric emptying motility only for the pre-lung transplantation patients, and we will always try to put jejunostomy in these patients. Let's see. In case of marked esophageal stenosis by cancer, how to access by ordinary GD? So in this case, we will always try to use the push technique, meaning that we can insert a nasogastric tube, which is very thin and will pass in the majority of the strictures, the esophageal strictures, and you will not have to place you have to push the push technique, so that the tube will not pass from the stricture. And in the very rare cases where you cannot pass the nasogastric scope, in this case, the radiologist can do it without passing anything, but this is extremely rare. In most cases, with the nasogastric the nasoendoscope, you will be able to put the tube by the push technique. So have you seen fewer cases of buried bumper with core flow pegs compared with FRECA? It is true that the ones, and it's not only FRECA, it's also Nutricia, the ones will have these bumpers that are very flat and a bit rigid, are the ones that will give mostly the buried bumper. The ones that are a bit curved, like the core flow, I'm not aware of that, but the Cook, for example, they're curved and a bit floppier. They will give less buried bumper. But in any case, we really try to insist really to give this in-out movement once per week to be sure that the bumper is free. How long until defect to heal? So this depends on the patient. It's, I would say, 2 to 3 weeks. And that is the period where you should not try to replace the tube. If it's a balloon, for example, tube will deflate and come out. It can be dangerous to try to replace it. And we know that from 4 weeks afterwards, it's majority have healed. And in this case, you can try to replace the tube. So how many centimeters will you leave between balloon and the skin? So when you place the tube at the first place, if it's a bumper, if it's a balloon, you will put it tightly together. This is to also to try to have a control a bit on the bleeding. This could be a way to control the bleeding from the stomach wall and the skin. And this you will relieve a bit after the first or 2 days, and you will leave maybe 5 millimeters between the balloon and the skin. And then you will wait another day or 2 days to really do the in and out movement. But I would say you need 5 millimeters after you've inserted it, and that's what you leave for long term to avoid also the mobilization of the tube through the skin, through the tract that might give also granulomas and other complications. So leakage and granulation tissue. So the granulation tissue, this we can nicely treat it with either with APC if you have a big granulation, You can do it with argon plasma or with nitrates, like you do the warts, for example, and this can be done by the nurse, but you have to be very careful to do only the granuloma tissue and not to touch the surrounding skin. So usually we put some Vaseline on the surrounding skin and only treat the granulome tissue, but it will respond well to this kind of treatment. So what types of PEG do you use for venting? This is a very good question because we will use large tubes. We use 24 French tubes, and this will allow the patient to be comfortable. Also, he might be able to drink something, to have some soup maybe, just for the feeling of the taste, and this will arrive in the stomach and then be vented. So this is we try to put the highest 24 French ones. Mini PEG, I suppose this is the buttons, the low profile PEGs that we can use as well. So these are very short button-like PEGs with the balloon type, and this will definitely use in children and also in young adults. And of course, will be replaced afterwards. You cannot have an initial access with this kind of tube, but you will replace it afterwards after discussing with the patient. This is the advantages is very discreet and very good for active adults and children, but it might be more difficult to handle because it's smaller pieces and the connections are a bit more difficult. So we will not put this, for example, in a neurological patient, but mostly in somebody that does his caretaking by himself. So about closing the orifice, that's also a very good question because this is one of the rare problems that we have, but that can be very problematic. When we take out the tube and you have to close the fistula does not close spontaneously, we will wait. This will more often occur in patients that are very fragile, that's mostly on jejunostomies than gastrostomies. If this happens, we can try to close the orifice with an over the scope clip, a macro clip. It is not 100% efficient either. It might reopen, and sometimes we need to go to surgery. But I would wait a bit more. I would wait maybe 4 weeks at least before proposing this kind of treatment, knowing that the success rate is not 100%. So if a patient has a high risk of extubation before 3 weeks, would you use a T-fasteners or the pull technique? This is a good question. It's we only use the T-fasteners when we put the push technique, and this we use only for when you have a head and neck cancer situation or a stricture. But if the patient has a high risk of extubation, we can use the pull technique and put the fasteners. The fasteners not always will help you during the procedure to put your push tube easier, but they will also help in increasing the rate of the healing. And so you will have healing in maybe 10 days instead of 3 weeks. So there's no studies for, of course, but this could be an extra precaution in this type of patients. Putting the T-fasteners will not really complicate or prolong the technique, so you can do that. Leakage, again, we talked about the granuloma. Other tricks is the PPI, or if there is high gastric residues, to use prokinetics. Sometimes you will have leakage because the orifice is enlarging. This can happen in patients with chemotherapy. And this, unfortunately, there's nothing you can do. If you put a larger tube, the orifice will continue enlarging. So this is sometimes related to the adjuvant treatments, chemotherapy that the patient have. So this, yes, again, the exploration of the abdominal wall, these are difficult patients. Sometimes this is very important, and we cannot manage with by putting protectives on the skin. We will have to stop the enteral feeding at this time, put everything on venting with a sac and wait till everything just heals. And this might take 10 days, 2 weeks. We will need parenteral nutrition in this case. And sometimes we can manage to salvage the problem and start again feeding progressively. These fortunately are very rare cases, but sometimes they're very difficult to handle. So I don't know if there are any other questions.
Thank you very much, Professor Marianna. That's the end of our questions. You've answered them all. So thank you very much for being with us today. And we hope to see you soon.
Thank you very much. And thank you very much for the very interesting questions. We can see that the audience was very expert audience, because these are usually the questions that we also still have. So it was very nice talking with you guys.
Thank you very much. Thank you. Thank you, everyone, and see you next week. Thank you.